Test positioning. Subject lies supine with the test hip flexed 45 degrees, knee flexed to 90 degrees, and tibia internally rotated 15 to 20 degrees. The examiner sits on the foot with both hands behind the subject's proximal tibia and thumbs on the tibial plateau. Action. Apply an anterior force to the proximal tibia. Hamstring tendons should be palpated frequently with the index fingers to ensure relaxation. Positive finding. Increased anterior tibial displacement, particularly of the lateral tibial condyle as compared to the uninvolved side, is indicative of anterior rotary instability. Secondary to a partial or complete tear, primarily the ACL and posterolateral capsule. Special considerations. The examiner must avoid maximally rotating tibia, as this will tighten most of the surrounding structures and create a high potential for false negative findings. Slocum test with external tibial rotation. Apply an anterior force to the proximal tibia. The hamstring tendons should be palpated frequently with the index fingers to ensure relaxation. Positive finding. Increased anterior tibial displacement, particularly of the medial tibial condyle, as compared to the uninvolved side, is indicative of anteromedially rotary instability, secondary to damage to primarily medial collateral ligaments, MCL, ACL, and the posteromedial capsule. Posterior drawer test. Test positioning. The subject lies supine with the test hip flexed to 45 degrees, knee flexed to 90, and foot in neutral position. The examiner sits on the subject's foot with both hands beside the subject's proximal tibia and thumbs on the tibial plateau. Action. Apply a posterior force to the proximal tibia. Positive finding. Increased posterior tibial displacement as compared to the uninvolved side is indicative of a partial or complete tear of the PCL. Special considerations. It is important to maintain quadriceps and hamstring muscle relaxation during the test. While applying a posterior force, the examiner should carefully assess any posterior step-off from the tibial plateau on the femur. Valgus stress test. Test positioning. The subject lies supine with the knee in full extension. The examiner stands with the distal hand in the subject's medial ankle and proximal hand on the knee, laterally. Action. With the ankle stabilized, apply a valgus force at the knee with a proximal hand. This is performed with the knee in full extension and repeated with the knee in 20 to 30 degrees of flexion. Positive finding. Medial knee pain and or increased valgus movement with a diminished or absent endpoint as compared to the uninvolved knee is indicative of the damage to primarily the MCL, PCL, and posterior medial capsule when found in full extension, and MCL when tested in 20 to 30 degrees of flexion. Special considerations. The examiner must avoid allowing the femur to internally or externally rotate during the test. This may give the illusion of increased valgus movement. This may be accomplished by using the treatment table to help stabilize the subject's femur. Varus stress test. Test positioning. The subject lies supine with the knee in full extension. The examiner stands with the distal hand on the subject's lateral ankle and proximal hand on the knee, medially. With the ankle stabilized, apply a varus force to the knee with the proximal hand. This is performed with the knee in full extension and repeated with the knee in 20 to 30 degrees of knee flexion. Positive finding. Lateral knee pain and or increased varus movement with diminished or absent endpoint as compared to the uninvolved knee is indicative of damage to primarily the LCL and PCL and accutate complex when found at full extension, and LCO when tested at 20 to 30 degrees of flexion. Special considerations. The examiner must avoid allowing the femur to externally or externally rotate during this test. This may give the illusion of increased varus movement. This can be accomplished by using the treatment table to help stabilize the subject's femur.
test, the subject stands and the examiner stands in front of the subject and places the thumb over the lateral epicondyle of the involved knee. The subject is instructed to support body weight on the involved foot and actively flex the knee as if performing a squat. The examiner maintains pressure with the thumb over the lateral epicondyle. If pain is present under the examiner's thumb when the subject's knee is positioned in 30 degrees of flexion, the IT band friction syndrome is indicated. At 30 degrees of knee flexion, the ITB lies directly over the lateral epicondyle. This is an active weight-bearing version of the Noble test.
Test positioning. The subject lies on the table with the uninvolved knee flexed to 90 degrees and the ipsilateral hip placed at 45 degrees of hip flexion. Action. The examiner observes position of the tibia relative to the femur and the sagittal plane. The examiner then instructs the subject to actively contract the quadriceps muscle group and attempt to extend the knee while retaining hip flexion. The ipsilateral foot should remain fixated to the table during the attempted knee extension. Positive finding. Posterior displacement of the tibia upon the femur while the subject's quadriceps remain silent indicates a posterior instability. This may be reflective of the entry to any of the following structures: posterior cruciate ligament, accurate ligament complex, and posterior oblique ligament. Special considerations. It is imperative for the examiner to identify a neutral tibiofemoral joint position, as this test can be misinterpreted for an anterior instability when one observes the anterior translation of the tibia on the femur.